hip arthroplasty. الحقيقه الموضوعين دول موضوعين كبار، بس عشان التايم فريم والكونفاينس بتاعت التايم هحاول ابقى ابيت كويك عشان اكفر از ماتش از اي كود. الاوبجكتيف بتاعنا ان احنا ندسكس biomechanics of the hip joint, passing through kinematics, kinetics, free body analysis and diagrams, determinants of joint traction force, applied biomechanics in hip disorders. وبعدين هندسكس التوتال هيب arthroplasty, applied biomechanics, mainly design philosophy, offsets, frictional torque force, volumetric and linear wear, and hip instability factors. I think the terms were well covered by my previous colleagues. Moving to kinematics of the hip, flexion range up to 120 degrees, extension 30 degrees, abduction 50, adduction 30, external rotation 45 degrees, internal rotation 45 degrees. Kinetics, as we all know, the dynamic forces on the hip are enormous. Normal walking exerts 3 times the body weight. We always refer when we are discussing the hip joint to the body weight. And sometimes in fast walking up to 7 times. And twice during straight leg grazing. 10 times in running. One application is when we get the patient served in bed. While he's putting him on a bed pan, unaided, the joint reaction forces accounts up to 4 times body weight. Much reduced with using overhead trapeze. The free body analysis of the hip makes certain assumptions. First, that the patient is standing in a single leg stance, and the weight of that leg is 1/6 of his body weight. And to further reiterate on Gopal's question previously, that the direction of action of the abductor muscle force is very important. It comes downwards from the pelvis toward the greater trochanter, so as to stabilize the pelvis rather than from downwards to upwards. And as we could see here in this figure, that the force is working around the hip, as previously discussed, the weight, and here we assign it 5/6, as we said previously, this is 1/6 of the body weight, and this is the force of the abductors. Both works through lever arms. As we could see here, roughly speaking, on average, the lever arm of the body weight is about 3 times the lever arm of the abductor force. And for a given body weight, if we could make our calculation, that the summation of all these forces around the geometric center of the femoral head equals 0. So if we calculate that, we could find that the force of the abductors equals to 2.5 body weight. Right, we have to appreciate that the abductor force is working, again, this has been reiterated before, but the abductor force is working on that direction around the geometric center of the femoral head, which means it's anti-clockwise, while the body weight is working clockwise. All right, this is very important to appreciate in the start of our presentation. Furthermore, the hip joint reaction force, which again, if we could summate the forces around the hip, it should equal 0. Meaning the force generated by the abductors in addition to the force generated by the body weight must equal the joint reaction forces which works in the other direction. Here there is some concept of the closed triangle force. As we could see here, that's the direction and the vector of the body weight, which is 5/6, and that's the direction of the abductors. Now if we are going to add to them the ground reaction force in the other direction, this closes a triangle. And making simple calculation, we could appreciate that the joint reaction forces is 3.3. Right. Now, very important to appreciate again, just to simplify, that the forces working around the hip are mainly the body weight and its moment arm, and the abductors muscles and its moment arm. Okay, I hope this is quite clear. Now, so these forces are working against the joint reaction force. So the question now, what are the determinants of the joint reaction force? Simply body weight, simply abductor muscle, simply moment arm here and moment arm there. Applying that to the hip disorders, the common pathoanatomy is either increased body weight, moment arm. These are the first 2 factors, and the others are decreased abductors force or decreased abductors moment arm. Working on that, equation, as we said before, joint traction force equals the body weight plus the abductor force. So what are the strategies to reduce the joint traction force? Obviously, to reduce the body weight or its moment arm, or help the abductor force or its moment arm. Right, the first is to reduce our body weight. Obviously, it will decrease the joint traction forces a lot. Second, triangular gaits. Actually, when we see the patient walking like that, we think it's actually weak abductor, just weak abductors. Actually, it's a compensatory mechanism by the body. When the patient has some pathology in his hip, when he leans over the diseased hip, what actually is done is decreases the body weight moment arm. As we said, either to decrease the body weight or to decrease its moment arm. So when the patient comes leaning a bit toward the diseased hip, it decreases the moment arm of the body weight. And then consequently to that, the functional demands on the abductors are decreased, and hence the joint traction force decreased. I'm sorry if I'm a bit quick. How could we help more? We could help the abductor force or its moment arm. How? By walking stick in the opposite hand, and I'll explain that, and this is quite practical. Suitcase or heavy object in the ipsilateral hand, and it's a bit theoretical. Right, to start with the walking stick. The effect of walking stick in the contralateral hand, basically the walking stick, when we put it in the contralateral hand, it exerts upward force, thus helping the abductors by reducing the body weight. I'll further reiterate on that. Consequently, smaller abductor force, and again, by decreasing the abductor force, the joint traction force would decrease. I hope this would explain. As we said, these are the forces which we discussed before. We did appreciate that the abductor muscle force works anti-clockwise. The body weight works clockwise direction. What about the walking stick in the other hand, on contralateral hand? This is again another anti-clockwise. So by summation of these forces, these two forces counteract this force. And by this results in lowering of the abductor muscle force, obviously, because if we summate that in comparison to that. And by putting the stick in the other hand, by increasing this lever arm, again, we would further decrease the forces, or the magnitude of forces should be done by the muscle. Okay? And actually, studies have shown that by using the stick in the contralateral hand, this aids in reduction of 67% of the forces from the abductor muscles. And again, the bigger the C, the moment arm, by putting the stick in the other hand, this reduces the forces on the hip, and consequently the work should be done by the abductor muscles. There is a very nice paper reiterating on that. This study, I think, in UK was done, and they collected the patient by questionnaire, asked them, did anybody tell you where you should put the stick? And 47% of the patients found to be using the aid in the incorrect hand. And this group, actually, 64% of them using this just in the dominant hand. So if they are left-handed, they put it in the left hand and vice versa. And actually, 66% have never been told. They claim that. I think this is a very simple measure to transmit in our community. Whenever any patient comes to you with hip pathology, you have to tell him, if you are going to use a stick, it should be on the contralateral hand. And if you have to carry some heavy object, unless it's obviously it's better for him to carry heavy objects, but if he's ever going to do that, he has to carry the suitcase in the ipsilateral hand. And this the study shows, again, this is anti-clockwise moment, so it's better to be in the same hand. But why this is confusing? The other one was anti-clockwise, but this is because this exerts a downward pressure force rather than upward pressure force. Again, as we said before, in addition to that, we could increase the abductor lever arm by increasing the offsets. I'm coming to that in a minute. Osteotomy and greater trochanteric lateral transfer, and this used to be done in the days of Sir John Charney, as I'm going to mention later. Now, quickly, we are starting with the total hip arthroplasty. Right. What are our targets to do, or our aims in hip replacement? Obviously, to relieve pain by excising the painful joint and also improve the function. And we put certain things we could improve during doing our total hip, performing total hip by optimizing our offset and increasing the lever arm. Design philosophy, actually there are two very well-known design philosophy. The one by Sir John Charney used to have a collar to prevent sinking, rough surface to promote bonding, but all interfaces were fixed, which is referred to as composite beam. And this is found to have high shear stress, low compressive stress, and medium tensile stress. So high shear, low compressive. The other philosophy by Rupert Lang, which is used to work in Exeter, his design philosophy: no proximal color, polished taper. We're all aware of CPT design from Zimmer. Actually, this is the same concept in Exeter as well, and it refers to colorless polished taper, CPT. And the main philosophy on that is it's taper slip. So actually, it's bone interface fixed, but the stem, the interface between the stem and the cement is not free. It's free for slippage. So actually, after you implant the total hip, it allows some subsidence, but we call it controlled subsidence rather than not controlled substance, which converts the shear stresses into radial compressive forces. And again, this aids in more fixation of the implant into the bone. And this is the photo of the Exeter, our beloved prosthesis. Very important items should be memorized in total hip replacement. The ideal femoral reconstruction should ideally reproduce the normal center of rotation of the femoral head. This location of the geometric center of the femoral head is dictated by three factors: medial offset, horizontal offset, or simply the offset. Whenever we are intraoperatively, sometimes we refer to this simply as the offset. So when we say the offset and just stop adding any words, we mean the medial or the horizontal offset. When we speak of vertical height or vertical offset and the version or anteversion. Right. First, the medial offset. It actually, if we could see here, the geometric center of the femoral head extends from there up to a line passing through the distal axis of the stem. And this is the most important single step you have to adequately restore inside the operation. And actually, restoring that starts before the operation by preoperative planning. And this could not be overemphasized, because failing to plan is planning to fail. Again, you have to plan before surgery. You have to be very careful before tackling your patient, because if in the not ideal scenario you have valgus or varus patient, if you are not going to do proper templating and proper planning before that, you will be in mess. Right. If we are going to decrease the offset, what would happen? This shortens the moment arm of the abductors, increase the joint reaction force, as we said before, and also the patient might limp and bony impingement. And again, it might result in dislocation. So if instead of this to be properly restored, if it was shorter a bit, this results in all that: increased joint reaction force, limping, bony impingement, and might be dislocation. On the other hand, if we are going to increase the offset, as sometimes happen, increased stress is found to be within the stem and the cement mantle. Again, this leads to stem fracture and loosening. Also, we have to appreciate that inside the operation, rather than to obtain more stability, but feeling that the patient, that the total hip whenever we are doing it is a bit over tight, this is not very recommended, because the patient most probably will have severe pain post-operatively. But also studies have found that it has a negative effect on joint lubrication and increased wear. What are the other offsets? Vertical offsets, and basically the vertical offset, as we could see here, it's from the geometric center of the femoral head to any fixed point, commonly referred to like the lesser trochanter or 1 centimeter more. Restoring this distance is essential to limb length discrepancy, to achieve the proper length and to avoid limb length discrepancy. We have to appreciate that whenever we are increasing the offset of the vertical height, both increase the neck length, and we have to be very careful. And it's a balance between increasing the length and adding more stability. And the surgeon, only experienced surgeon inside the operation, is able to make that decision, right? In most modern systems, there are some things called enhanced offset, which helps the surgeon a lot by achieving the proper tension of ductal muscles without a lot of lengthening of the limb. To the version, it's very simple. Refers to orientation of the neck in reference to the coronal plane or the transapicondylar axis of the knee joint rather than the hip. And restoration of version is obviously very important. If we are going to put the patient, our hip in retroversion, this leads to posterior dislocation, and vice versa for excessive anteversion, which leads to anterior dislocation. Now, a couple of words. My colleague Sharif Khalid is going to explain the word, but a couple of words. There is some term called the sliding distance. What's that? During certain arc of motion, the sliding distance of one component on the other differs according to the diameter of the head. So in this diagram, we see here that's the small femoral head used to be used by John Charnley, and the other large head which we use nowadays. The sliding distance here obviously is smaller than the sliding distance here. And what's volumetric wear to start with? This is the total volume of debris removed. It's found that it's directly proportional to the sliding distance. So larger head has larger volumetric wear, smaller head has smaller volumetric wear. But actually studies have found that the volumetric wear is less important than the penetrative wear, which I'm going to discuss in a minute, because they found that the volume of polyethylene removed by wear is not usually given as much attention in the design of the prosthesis as the linear wear. The other type of wear, as I just mentioned, linear wear, which is more important. This is a measure of the penetration of the head through the socket and is a cause of clinical failure of the prosthesis. And it's found to be inversely proportional in contrast to the volumetric wear to the sliding distance. So in other words, with using the small femoral head, we decrease the volumetric wear, but on the other hand, we increase the penetrative wear. So long, as we said before, that the linear wear is more important than the volumetric wear, a large head is a bit preferred against small head. Right, the other term is frictional torque force. What's frictional torque force? It's actually the product of frictional force times the length of the lever arm. And again, this could be considered as a term of the sliding distance. It's found that the smaller heads have less frictional torque force, obviously, because the length of the lever arm or the sliding distance is small. And as we discussed before, that was the essence of low frictional torque arthroplasty popularized by Sir John Charnley in 1960s. This used to be a very successful prosthesis. Until now, the patients are coming to Wrightington in England using his prosthesis. And this is John Charnley, as I said. He used to do routine lateralization of the abductors to increase the offset, as well as medialization of the center of rotation by deepening the sockets and using a small head size. Are we still doing that nowadays? I don't think so. Because the modern implants and the modern technology and the taper free slip came into the market mainly by Exeter and CPT, we no longer do that. Instability. 4 major factors affect the instability: component design, component position, soft tissue tensioning, and soft tissue functioning. Right, there's something called primary arc range. This is defined the arc, the articulation moves before impinging and levering out. What does it mean? If you could see here that the 22 millimeter head, and that's the acetabular components, 180 degrees, the head could move in this sort of range before impinging here, right? And this is found to be 100 degrees range of movement before impinging. Comparing the head-neck ratio, using a small head versus a large head with the taper or more taper the same, we could find here that the range of the small head is 100 degrees only before starting to impinge, whereas the large head, it will be 120 degrees before starting to impinge. So a larger head-neck ratio would allow a bigger or larger arc of a primary arc of movement. What's the excursion distance? At some point, we will achieve we will reach to the primary impingement. And the head then starts to lever out of the cup and consequently start to dislocate. The excursion distance, the larger the excursion distance, the more stable the head. Again, the excursion distance is dictated by the diameter of the femoral head. And again, if you are comparing 32 millimeter head to 22 millimeter head, obviously it will be half, as I said before, so it's 16 more than 11. So we would consider, that's why we would consider the larger head is more stable, and that's the essence behind the large head in arthroplasty nowadays. Taken to the extreme, obviously the hemi-arthroplasty or the bipolar arthroplasty, the head is most inherently stable because it has a very favorable head-neck ratio. Side of the taper, again, narrow neck tapers provide more stability via more favorable head-neck ratio, because if you are going to use a small taper, this means that the head-neck ratio is bigger, and this allows better excursion distance. Conversely, the addition of collar, or rather what we call a skirt, when we go to extra long inside the operation, we don't quite like that unless we are terribly in need to do. because this actually exerts more pressure, and also this increases the neck diameter and adversely affects the head-neck ratio, and then consequently lead to more failure. Sometimes when we use some components, we use what's called LPW, long posterior wall, or the other way around is EPL, elevated posterior wall, and by, see the difference, here the same head, here without the posterior augmentation, we could achieve up to 100 degrees of motion. When we put this posterior lip, it's 80 degrees. Sometimes we use that in the posterior approach to decrease the dislocation, but actually I have to reiterate here, we have to put the patient hip in the geometric center and to avoid the need for this augmentation. Sometimes the surgeon thinks it's easier for him to use it, but actually it's of some untoward effects on our fixation of the implant. Again, I said the head-neck ratio before. Right, what about constrained liners? I'd advise every single body in this room not to use it unless really in terrible need, like 75 years old or 80 years old with no abductor forces at all. Because as we could see, the primary arc range is decreased up to 60 degrees. And again, there is massive pressure and effect on the implant acetabular surface, bone cement here. And when these fail, because the repetitive impingement imparts a leading force on the acetabular components, leading to early loosening. So actually, this patient is not going to dislocate from the cup. Actually, the cup is going to dislocate from the acetabulum. So please don't ever use it unless you are in terrible need to use that. Quickly, as we said before, there is something called primary arc range. We have to appreciate that when we put the component, ideally we should put it in the center of the primary arc range of the patient. If we are going to put our total head in extreme position, or our cup, as we could see here, that's the patient primary arc range should be from here to there. And then we put our cup here in the extreme. So as we could see here, the excursion distance on that side is very increased. This means that the patient is likely to dislocate in this direction. Again, a quick word, we all know that there's a coronal tilt, or what's called theta angle, which is around 35 to 45. Our favorite sometimes is 40 degrees. And in the sagittal plane, it's anteversion, ideally between 10 to 20. We can't reiterate the importance of soft tissue tensioning. And to obtain that intraoperatively, we have to play a bit with the offset and neck length to achieve proper offset and neck length, and consequently we could achieve proper soft tissue tensioning. And the fourth test for those who do total head is to see the telescoping or shack test, also the limb length, the stability, and the offset to see whether the offset is properly reproduced to its anatomical position or not. Finally, the soft tissue function, coordinated muscle action is necessary to maintain a stable hip, and this can be a problem anywhere along the neurological axis. Thank you very much.